Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is a part of the series on physician performance entitled Historical Metrics. This module is targeted to Level 4 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to understand how radiology groups have traditionally quantified physician performance, to describe the unintended consequences of incentivizing volume-based productivity, and to identify opportunities to incentivize individual physician performance in a manner that is aligned with broader group practice and societal priorities. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. One of the messages of REPLETE that hopefully is evident to you now is that payment policy and practice management initiatives and endeavors only work if all of the activities of all stakeholders are aligned. And since payments and scorecards are the way that policymakers are increasingly incentivizing value, we need to make sure that our activities at the individual practice levels are aligned with those broader societal imperatives and that our boats are rowing in that direction. The message of this module is that we have to make sure that all of our physicians are rowing in the same direction that we want our practice to be going. Because if we incentivize those physicians purely based on volume, but want our practice to move in the direction of value, then all we will do is spin aimlessly. And like it or not, the culture of most radiology practices is still anchored in chasing RVUs, relative value units. What that means is that many still use measures of volume rather than value as the way that they assess and reward their physicians. Such practices, and there are many, narrowly focus on productivity rather than physician performance more broadly. It's a topic of the article you see here on what a number of thought leaders call the hyper-efficient radiology practice. In that article, Dr. Jack Crow outlines some differences in how various types of work assignments can result in different expectations for generated RVUs. It's interesting how the article has been interpreted by some. I know of one radiologist who focused on the differential RVUs between interpreting CTs in an environment with frequent interruptions versus one in which there are no interruptions. That radiologist's take-home point was this: I can increase my throughput by 40% if I simply lock the door to the reading room and take my phone off the hook. And that way, I'm not interrupted by technologists or my partners or by my referring physicians. Hopefully you realize that that's not providing value, and perhaps a good way to get you fired, or maybe get your group's contract with the hospital canceled. Highlighting the importance of value-enhancing activities in an era in which physicians have historically been incentivized with RVU volume-focused measures, former ACR board chair Dr. Paul Ellenbogen wrote several years ago about radiology's dirty P word. He means, of course, productivity. His compelling message was an admonishment to all of us that we not myopically focus on RVUs when we assess the performance of our radiologists. His point was this: fee-for-service doesn't appropriately compensate, at least currently, value-focused activities. And his ask was this: would it be so bad to take a 10 to 15% cut in our pay to protect the other 85 to 90%? Dr. Ellenbogen's point is that we can't just be invisible radiologists who do no more than dictate reports from a hidden bunker, and that our relevance can be enhanced by shifting just 10 to 15% of our work into various value-enhancing activities. They're the types of things that we have talked about before in REPLETE and that we'll spend some more time on in a bit more focused manner in a future module. That number of 10 to 15% turned out to be spot on, because that's the ballpark amount in which your payment from Medicare will either go up or down under MIPS. Remember this graph? The blue line here will essentially be the RVUs, the volume that your practice generates. But what you get paid will go up or down, and potentially by a lot, based on a variety of value-based metrics that we've talked about previously. And so we just can't ignore those. Remember, here's how your composite score will be calculated under MIPS. If you completely dismiss quality, and you completely dismissed cost-saving activities, and you completely ignore information technology needs, and completely disregard requirements to continually improve your practice, then you'll get a really bad score. And that means you'll get a report card that looks terrible compared with your colleagues who do prioritize all of these things. And under the Medicare Quality Payment Program, that also means you'll take home a lot less pay. And so in this module, we'll spend some time talking about traditional productivity metrics and some of their unintended consequences. In the next module, we'll focus more on value-based metrics and some ways to put all of this together in what I think is an actionable manner. Let me warn you, though, that the topic of performance evaluation in many radiology practices is not for the faint of heart. In Washington, politicians call Social Security and Medicare the third rail. They're referring to the electrified third rail of the DC Metro, which carries thousands of volts. Touch it and you die, is what they say. And in some sense, if you're a practice leader and you aren't careful about how you address performance measurements and incentives with your group, you could find yourself facing some quite electrifying challenges as well. Let me start with a story that got me interested almost 2 decades ago in the whole topic of physician performance evaluation. Here's an RVU breakdown of the partners in a group some 20 years ago that asked me to help guide them in this manner. You see the partners' RVU numbers from 1999 and 2000. It is a way back, but the story still holds true today. The y-axis itself, which I've redacted here, isn't really important, and in fact, it's confidential. What is important, though, is that the group had 3 outliers that you see to the left of your screen. One partner in the group whose behavior made this all a flashpoint was the one who spent lots of time, very visibly and very unapologetically, coordinating local March Madness and fantasy football activities and whatever sports activities were hot in any given season. He was also an older radiologist who almost exclusively interpreted plain films, and so it was his job to clear the old rotators where the old films were hung. But unlike on days when other partners covered that slot, those rotators remained full of unread films as 5 p.m. approached. And so, as the story approached, he had the gall to get on the loudspeaker in the department and make this proclamation. Films are loaded on all 3 alternators for your viewing pleasure. And then, when nobody showed up to help him because they were covering CT or ultrasound or IR, another announcement went out around 5 p.m. It is now 5 o'clock. This is your second notice. Films are loaded on all 3 alternators for your viewing pleasure. Remember, it was supposed to be his job to read those studies. But at 5:05, the microphone went quiet. You see, at this point, the senior partner was already gone for the day and left things for his junior partners to clean up. And so, while 2 of the other lower producers were tolerated by the group as being good guys who covered services that just didn't generate a lot of RVUs, plain films and GI fluoro studies, for example, it was the behavior of Mr. Microphone, who was similarly at the bottom of the pack in RVU generation, that prompted that group to say, we need to develop a productivity policy. That was not a very good way to start off a thoughtful process of evaluating physician performance. You can imagine the acrimony that pursued. And there are good reasons to measure physician performance, and even specifically output productivity, at least as a part of that overall performance. But this was not one of them. So why, after me warning you that this could be politically treacherous, why would you want to measure physician performance? You see the list here. You can't manage things that you can't measure. And groups, of course, want to optimize our physician productivity. We want to use our physician resources as wisely as we can. Part of that means enhancing your practice's income and maximizing your time away from work. But also, increasingly importantly, we want to promote desired non-clinical behaviors. Ultimately, if you're doing this right, you can use performance measurements and incentives, and I'm talking more broadly than just RVUs now, to move your group toward a shared vision with shared common goals. And so, while it isn't a topic in Replete, one important thing to think about is whether your group has a shared vision and shared common goals. That is, you ideally want to get everybody on board together, deciding as a group where you want to go and how you will get there. Part of that journey means realizing that everyone plays a different but yet important role, each a different piece of an important puzzle. That's the way that many visionary groups create their culture and enhance their success. We'll talk about some of those leadership and citizenship criteria in the next module. But for this module, let's continue to focus, intentionally and admittedly myopically, on clinical productivity. In my talks, I intentionally use the terms productivity and performance differently, and would encourage you to do the same. Doing so, I think, will help you really distinguish what many people measure now from the things they should be measuring, and the things that will be forced to measure as healthcare payment and delivery systems evolve. In the context of physician work evaluation, productivity is pretty simple. It means how much you did. It's measuring volume, plain and simple. It's a relic of plain old fee-for-service, and as you know now, that approach is encumbered with all sorts of perverse incentives and unintended consequences. When we talk about performance, we're talking about physician work more broadly. Sure, part of it is how many services that physician rendered, the numbers that we'll talk about in a bit. But we also need to consider how well those services were rendered. That is, the measures of quality that we've talked about before, like outcomes, service, and appropriateness. The things that form the basis of new and emerging value-based payment systems. And we must as well be thinking about the needs of our practices. How do we, as a group, stay as efficient, as impactful, and as stable as we can? That means doing a lot of non-clinical things. Making sure that our partners contribute to the practice's operations, whether it be billing, informatics, or relationships. And finally, we need to be considering the impact of all of those other things. How are things working? And is somebody really leading our practice forward in a meaningful way? Or are they just doing busy work, sitting at meetings? Or, worse yet, doing nothing at all? The right measure, as we'll talk about in the next module, considers the sweet spot of this Venn diagram, where all of those circles overlap. Recognizing that everyone will contribute a bit differently, but that all of their activities are nonetheless important, is how your group moves forward. In this module, we'll focus on the how much circle at the top of that Venn diagram. Here are 3 common ways that radiology groups have measured physician productivity: revenue, examinations, and relative value units. Not surprisingly, these are all rooted in dollars and CPT codes and RVUs, the building blocks of fee-for-service. Let's talk about them each, one by one. Let's start first with revenue. It's a direct measure of the economic impact of physician services on our practices, and it's easy to measure. It's dollars and cents. But remember that measurement incentivizes services to perform services to better insured patients. Some groups have used this model in the past. They say it's eat what you kill, bill for what you did, and it can sometimes be as ruthless as what it means out in the wild. It sounds simple. You read the study, you get paid for it accordingly. I read that study and got paid for it accordingly. You read the other study and got paid for it as it gets paid. But you can easily see how it can turn into a cherry-picking competition, with partners picking off high-dollar services for better insured patients, leaving lower-dollar services unread and ignoring the needs of all people within a community. And some potential for workforce mischief with, say, a senior partner who always assigns himself or herself to the posh suburban imaging center where patients have good insurance, with the new recruit in the practice covering GI fluoro at the county hospital with a lot of indigent patients. As a general rule, few groups do this anymore. Because of those that did, they went extinct. They lost their hospital contracts. Service to a health system and to a community matters, and it matters a lot when your group is renegotiating its contract. How about counting the number of examinations? Back in the old days, when most of a radiologist's day was spent reading plain films, groups often measured output in the number of examinations. As a general rule, the work intensity and dollars involved in reading a chest x-ray versus a KUB versus a lumbar spine radiograph were all quite similar. And so this was pretty much an apples-to-apples comparison. But those days are long gone, particularly as groups have gotten much more specialized. A chest x-ray and a brain MRI and an embolization procedure are each all coded with a single CPT code. But the work involved is vastly different. And so examination counting alone makes little sense anymore, at least as the only measure of productivity. We've talked about RVUs at length in the context of how Medicare assigns payments to services. Although RBRVS was never designed, and I repeat, never designed, as a tool to measure performance at the individual physician level, it's nonetheless what most groups use to measure their physician's productivity, regardless of that specialty. That is, radiologists and surgeons and internists all deal with this issue in their practices. By now, you're an expert in RBRVS, and you know that our RVUs are a resource-based measurement of physician clinical services, but that there's also some assumptions that aren't necessarily true. This is a bit of a political process, and so if you use RVUs, then make sure that you know how they can and why they can be used and when they can't. Make sure that you're measuring the right component of RVUs as well. You know by now that there are two types of RVUs that are intuitively the ones that practices might be drawn to: total RVUs and physician work RVUs. For the reasons that we have talked about in prior modules, and this should be intuitive, if you want to assess physician work, then the physician work component is the one that you want to measure, but groups do not. Some, at least. And remember, yes, physician work RVUs are easily measured, but it's a highly imperfect system. One of the problems of measuring RVUs, though, is that they don't really consider some of the inefficiencies involved in rendering high volumes of low RVU services. I'll show you some examples of chest x-rays and MRIs in a moment. So, some practices have developed their own homegrown metrics. One that I like was developed by my colleague Johnson Lightfoot from California. His group uses a contribution index. You see the formula here. It thus takes into consideration some of the inequities in RVU assignments and the relative inefficiencies in rendering lower intensity services. There's nothing necessarily right nor wrong about his formula, but it's a great example of how practices can innovate to develop homegrown metrics to best measure what's important to them. Keep in mind in the next module this idea when we talk about the fact that one size does not fit all. The bottom line with all of this is that while there are several measures of physician volume productivity you can use, by and large, everybody uses the RVU as a part of that measurement. For some, sadly, it's the end-all and the be-all. I think it's an important piece, but just a piece of a balanced scorecard. And assuming you agree, then your next challenge will be benchmarking. What is normal? What is good? What's not so good when it comes to an individual partner's RVU count? For that, many practices turn to benchmarks, and the ones they can use are listed here. Let's take a moment and talk about each of these separately. There's very little in the recent peer-reviewed literature establishing benchmarks, but let's review a few key articles from some time back. In Academic Radiology, back in 2001, Dr. Ron Aronson published survey data from 743 radiologists from 20 academic centers. On average, those academic radiologists interpreted 7,000 exams a year, which corresponded to nearly 4,500 RVUs. Numbers in a private practice setting, not surprisingly, are different and higher. Using data from 6 private practices in California, comprising a total of 236 radiologists, so we're talking some pretty big groups, David Monahan published his findings in the JACR in 2004. The number of exams in RVUs were almost double that of the academic benchmark that we just talked about, although, as you can see here, there was a pretty broad range. What I think was most important about this paper was that team reported RVUs on a per-day basis. That's an important thing to keep in mind. Some groups take more, some groups take less vacation than others, and sometimes people get sick or work part-time. And so that means comparing what you did in a year and what I did in a year, sometimes apples to oranges. Using data from a national survey performed by the ACR over several years, Maitrey Chatfield published a larger series in Radiology in 2009. Her survey reflected, as I'll show you in a moment, data from a mix of practices, including both academic and private groups. And overall, the numbers of exams and RVUs increased quite substantially over time. Remember the era here. Back around 2005, most practices were quickly transitioning from analog films to digital PACS workstations, and radiologists were getting a lot more efficient. One interesting piece of her work is that she compared the 2006 to 2007 survey data with earlier surveys performed by the ACR. And you see the results here. Exams and RVUs were steadily increasing over time. Radiologists were overall getting busier and busier. And that trend held true for essentially all practice types: solo, academic, multi-specialty, and private groups. To my knowledge, nobody has published similar data since, but I think most radiologists think that things have only increased since that time, and quite a bit. Given that our journals haven't had much recent information on this topic, to get good data today, you really need to go sources other than the peer-reviewed literature. Our academic practice uses data from the AAA-RAD, the Association of Administrators in Academic Radiology Departments, which reflects robust data from nearly all academic departments across the country. The reports are proprietary, which is why I've redacted actual numbers, but you can see here how granular and robust the data are, breaking benchmarks down by specialty. Similar proprietary data are available from the MGMA and the RBMA, and these reflect better benchmarks for multi-specialty groups and private practices, respectively. If you're going to try to do real benchmarking in your group, I would encourage you to take a look at these resources. One fascinating piece to all of this is that while everybody talks about measuring RVUs, very few radiologists know what's average for their own group. Here's a screenshot of a survey I performed several years ago using an audience response system at the Economics of Diagnostic Imaging National Symposium. Asking radiologists who say they're measuring RVUs in their practices, the data are pretty similar each year. Interestingly, with the largest number of respondents saying, "I don't know," to the question posed here. So we've got a bit of a disconnect within the specialty, and radiology practice leaders often advocating for a scoring system they don't fully understand. I'll emphasize again the problems in using annual data for benchmarking practices. As the saying goes, if you've seen one practice, well, you've seen one practice. Radiology groups vary considerably in their priorities, cultures, and schedules. Some take more vacation, some take less. Some work longer days, some work shorter. And within individual groups, there is considerable variation all the time, depending on a variety of features. So, if you join a group that measures this stuff, and most do to one extent or another, then make sure that group is normalizing their data, lest you unfairly ostracize, or worse yet, penalize people who have gotten sick, or say, going part-time during a period of pre-retirement. There are two ways to do this, and neither is right nor wrong. You can adjust part-timers to a 100% work effort. That would mean doubling the RVUs of a half-time radiologist. Or you can normalize on a per-day basis, essentially dividing RVUs by numbers of days. One problem with national benchmarks, though, is that they're national. They don't tell you what's right for you in your practice. And so I'm a big believer in the ruby red slippers approach to this. You remember Dorothy in The Wizard of Oz. There's no place like home when she was clicking together her shoes. Internal benchmarks can be very useful, as long as you look at them in the appropriate context that some services are RVU weighted more favorably than others. Here's the per-day RVU range for one group that I helped with this issue a few years ago in revising their metrics. You see, for example, the interventional radiologists here in red. So you can do color highlighting this to segment out people based upon their work patterns. The highest person in that group was a neuroradiologist who didn't have any administrative responsibilities. The lower person on the list was a senior radiologist who did a lot of plain films and minor procedures and GI fluoro cases, the stuff that no one liked to do. And so his work in that regard was much appreciated, particularly by the highly productive neuroradiologists who really hated to do that kind of work. So if you do measure RVUs, make sure that your group doesn't just focus on RVUs. In a group with a culture different from that last one, the neuroradiologist may feel entitled to make more money, even though he wasn't willing to do the dirty work that somebody had to do to let him crank out his brain and spine CTs and MRIs in an essentially uninterrupted manner. Let me show you some examples of how services compare. You be the judge of what seems fair. For example, you have to interpret 5 portable chest radiographs to get the RVUs of just one non-contrast brain CT examination. Or 6 portable chest x-rays to match the RVUs of one non-contrast sinus CT examination. Or 10 portable chest x-rays to match the RVUs of one brain MRI. Hopefully you can see now why, if all your group does is counts RVUs, why some folks may be inclined to cherry-pick normal brain MRIs off the list. Once you start looking at services that require hands-on work, things change even more. It's far less RVU efficient to do a paracentesis or a lumbar puncture than it is to interpret cross-sectional imaging. And GI fluoro studies are even worse with regard to RVUs. you'd need to perform 4 barium enema examinations to get the RVUs of 1 brain MRI examination. I refer to services like GI Fluoro as loss leaders, the necessary poor-paying stuff that you need to do to keep your group in the good graces of your health system, with a contract, so that all of your partners have jobs. Because if nobody does this stuff, then you're potentially all out of a job. This isn't just a theoretical issue. I know of one group that went completely RVU, eat what you kill, and quickly got fired by their hospital because nobody was willing to do the dirty work that was expected of them as part of their hospital contract. Being the highest RVU generator in a group that no longer has a contract is not a very enviable position. One other thing to keep in mind is that procedure counts and RVUs are all now easily discoverable in the event of a malpractice lawsuit. In the old days, it was hard for plaintiff attorneys to know what kind of volume you were doing. Now, your RAS and your PACS track all of this. And so if you're one of those high-volume practices, a plaintiff's attorney could use that against you. And I'm not saying that being fast means that you're dangerous, but you do need to understand that's how some malpractice lawyers might try to characterize you. Dr. Lenny Boleyn wrote about this some 20 years ago in a case you can see listed here. You see the allegation made against the radiologist for, quote, missing a breast cancer on a mammogram. Basically, the plaintiff painted a picture of a money-grubbing radiologist who was too busy cranking out services to be careful. I don't know whether that was true or not, but that radiologist settled out of court in that case for $1 million. And so if you're a high-volume practice, and even if you're really good and really careful, if you make a mistake, and we all will at some times in our careers, those high volumes could be used against you. One other thing to keep in mind is if your group tracks RVUs, and particularly if it uses them as the basis for how radiologists get paid, is that they can create perverse incentives. Here's a case from a practice I consulted with several years ago. You see the very minor right renal artery intrastent stenosis on the right. Several interventional radiologists that looked at this case for me said that they would not have treated this lesion, but this radiologist did. His group paid him by the RVU, and he called this minor stenosis a moderate stenosis to severe stenosis, which allowed him to justify performing an angioplasty, which back then paid pretty well. Remember the perverse incentives of fee-for-service? Well, they can and do come into play if you pay your individual doctors on a fee-for-service basis. Aligning incentives is a term I've used many times during Replete, and that's because it's at the heart of meaningful health policy. Incentives for payment need to align with what society wants from its doctors, and that trickles down to the practice level as well. If your group is going to be successful under the new value-based payment models that you now know a lot about, then you can't be paying your doctors based upon volume alone, because that's all you'll get from them. If everyone isn't rowing in the same direction, the boat just spins aimlessly. So in summary, many good reasons exist to measure physician performance, but there are some bad ones as well. Traditional RVU, volume-based metrics, while ingrained within the culture of many radiology practices, diverge from broader, emerging societal and practice-level goals. Understanding the attributes and limitations of various metrics will ultimately help radiologists develop and implement balanced scorecards that reflect the priorities of their practices and optimally align incentives for all. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the Replete initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Replete.